I have two or more debates today, and these are both very, very good debates. The first one that I've been asked to chair is a topic that was discussed at length with the planning committee, and we felt that this would be one of the highlights of the stroke program. And I'm sure most of you would agree. And the topic is an important one, which is withdrawal of care should never be performed within the first few days after an acute stroke. Somebody coming in with an acute stroke and discussing prognosis, the question is that this should never be done within the first few days. And this is important because when someone comes to the hospital, many of these patients may have directives that they don't want to have advanced life supports, whereas others, and it's been shown that people may change their mind also. So although previously some patients may have expressed a desire that if they were to come in with a very severe stroke or other severe disability, that they don't want advanced life support, maybe they change their mind. So the question, of course, has always been that can we determine early into a acute stroke the patient's prognosis and their long-term disability or not? So important discussions. So what we have is a debate. So on the yes side, we will first listen to Dr. Mead from the UK. And then for the no side also, we would have Dr. Ruth England, again from the UK, who'd have these discussions. But before we go into their presentations, as you've been seeing in the last segments, we want to take a vote. So the first vote is going to be before our presenters make the presentations, and then we'll have some discussion before we have our second vote. So can I just ask if we have the first vote now, please?
Ah, 35% yes.
Thank you. 35% yes, so 65 no. Well, we will start off with Dr. Mead's presentation.
Good afternoon. I'm Gillian Mead, Professor of Stroke and Elderly Care Medicine at the University of Edinburgh. I'd like to thank the organisers for the opportunity to speak today. The title of my talk is Withdrawal of Care Should Never Be Performed Within the First Few Days After Acute Stroke. I'd like to disclose that I've had research grants in this area. These views are presented for the purposes of this debate and do not necessarily represent my own views or clinical practice. Firstly, I'd like to talk about the scope and definitions covered in this talk. By few days, I mean about 5 days. Acute stroke is defined as sudden onset of focal or global neurological disturbance lasting more than 24 hours, assumed to be vascular in origin. I'll cover ischemic stroke and intracranial hemorrhage, but not subarachnoid hemorrhage, as the pathway for care of patients after subarachnoid hemorrhage is very different from the other stroke types. I'm going to talk about adults only, not paediatric stroke. Here is a summary of the key reasons why care should not be withdrawn early after stroke. Firstly, patients and families are in a state of shock after acute stroke. and this is not the right time to make life or death decisions. The prognosis for individuals is uncertain. Patients may not die after treatment withdrawal. Patients and families may find it too burdensome to make an early decision about withdrawal of treatment. Early withdrawal of treatment may prevent family from saying their final goodbyes. There are clinician-related biases in making this life or death decision. And finally, many patients who survive with severe disability after stroke report that they're thankful to have survived. Here is a diagram showing how early decisions can make the difference between life and death. This was produced by Claire Creutzfeldt and published in the BMJ a few years ago. So a person may have high initial functioning, an acute stroke occurs and their function deteriorates suddenly. Shared decisions then need to be made about their care, and this can lead to either end-of-life care or survival and recovery, but usually at a much lower functional level. But the point I'd like to make here is that these very early decisions can make the difference between life and death. We know that when people are faced with crisis situations, their capacity to take in new information and make decisions is compromised. Here's a quote from one of our studies demonstrating this. He was completely fit and healthy one day, and the same day just suddenly wallop. He was completely changed. So it was a bit of a shock. On the right, you can see a still from a teaching module that we've produced about effective and sensitive conversations towards the end of life. And this still attempts to portray the shock that families experience. Stroke prognostic scales are not sufficiently accurate to determine outcome in individuals. So this paper here was published in 2019, and it's a review of stroke scales along the vertical side and the left-hand side. So there's various different scores, and they include different potential prognostic factors. And the scales include a different range of prognostic factors. So the green bars demonstrate which scales include which factors. Now, one of the big problems of these scales and scores is that biomedical factors are included, but often other relevant factors such as frailty and comorbidity are not included. Best prognostic score for death has an area under the curve of only 85%. And furthermore, families often want information about recovery of specific disabilities and abilities, not just about death or not. The patient may not die after treatment withdrawal, and this could be because of medical complications such as seizure, sepsis and hypoxia that may have increased apparent stroke severity. So we'll all remember patients who were admitted with an acute stroke with a low Glasgow coma score and a hint that they may have had a seizure. It's very important in these patients not to make early decisions in case there has been another trigger for that low conscious level. And we also know that sepsis and hypoxia can make apparent neurological deficits seem worse. I'm sure you've also seen patients who've had large middle cerebral artery territory ischemic strokes with a lot of brain edema, whose conscious level is low. And as that edema resolves, the neurological signs improve and the patient rallies. So there are certain consequences of a patient surviving unexpectedly if you withdraw care. It can be very distressing and confusing for patients and families who expected death and not survival. Families may perceive conflicting stories, conflicting advice, and this can lead to some loss in confidence of the medical team. It also leads to difficult questions about whether to restart observations, and if you do you then treat subsequent complications actively. Do you restart hydration? Do you restart tube feeding? These decisions are hard enough to make initially, but to have to make them after somebody rallies who is expected to die is even harder. Families and patients may find early decisions to withdraw treatment too burdensome. Here is a quote from our 2018 study. Dr. X, she was a very nice person, but she really took me unawares when she said, "What do you think of your mother-in-law's quality of life?" And she said, "We could stop feeding her." And I thought, no, I couldn't cope with that. It's not for us to decide how long she's going to live. I was really, really upset. I said, "You can't do that." And she left it at that. Here's another quote. "We, the family, don't want them doctors to withdraw treatment. You want them to give 100% and keep going no matter what to stay alive." And another quote, "I think he wants to get better. He's not ready to die." These days, many of my patients have families spread all over the UK and overseas. And early withdrawal of treatment can prevent families from saying their final goodbyes. And I think one has to think about families going forward. We have a responsibility for their well-being, and it could well help their grieving process if they feel they've been able to say goodbye to their loved one. The literature also suggests that there are clinician-related biases in decision-making. And here is a fascinating study published in JAMA in 2005. There were certain clinician-related factors associated with withdrawal of care. It included younger age, being white, having an over-pessimistic prognosis, personal beliefs, misunderstanding family, patients' values and beliefs, and also a failure to appreciate the extent to which a stroke survivor can adapt to a life with severe disability. I would argue that these sorts of biases should not be allowed to influence life and death decisions. And so to avoid this, all patients should be actively treated in the first few days. Patients with severe disability after stroke are often glad to be alive. Here's a study published in 2000. 71% of hemiplegic stroke patients, compared with 39% of controls, preferred disability to death. And here are some quotes from stroke patients with severe disability. One said, "I overheard someone very recently saying that if they're not going to get better, they would want to die. Not me. I'm a fighter to the end. I would like just to have a more active life. If mobility comes, it comes. And if it doesn't, well, that's fair enough." So here there's an acceptance that actually life with disability may not be as bad as expected, and that people want to fight to stay alive at all costs. So, I'd like to summarise by saying there are many good reasons why treatment should not be withdrawn in the first few days. I've shown that it's impossible to predict sufficiently accurately whether somebody is going to die or not. And it's even harder to predict what their quality of life will be and how well specific abilities will recover. Family is often in shock, and so is the patient. And this is not the right time to be making life or death decisions. Survival, despite treatment withdrawal, which does often happen, leads to even more challenging decisions about restarting treatments. We know that there are intrinsic clinician biases, for example, being young and white, and that these should not be allowed to influence life or death decisions. We also know that many stroke survivors with severe disability report that they are glad that they have survived. So for all these reasons, I would argue that treatment after acute severe stroke should not be withdrawn in the first few days. Thank you very much.
Thank you for inviting me to speak against the proposal that withdrawal of care should never be performed within the first few days after acute stroke. It's an honour to represent my specialty on this esteemed platform. My name is Ruth England. I'm a consultant in palliative medicine in the Midlands in the UK. I don't pretend to stand here with any great authority. As we know, there's little published guidance about palliative care specific to stroke. So what follows is a collection of ideas based on my experience and knowledge from a palliative care perspective. Any particular interest, I claim, can only derive from the fact that I'm married to a stroke physician. I work in a hospital palliative care team in a busy general hospital where we see about 2,000 patients a year. But in nearly 20 years of work, I confess I've supported the parent team caring for patients after acute stroke only on a handful of occasions, sometimes to support decisions about hydration and nutrition, or if there are difficult symptoms, perhaps where there is cancer comorbidity. We might reflect on the wider implications of these facts in our later discussion. I also make no pretense of being an expert in global policy relating to end-of-life care. We live in a richly diverse world where different communities have different views and approaches to healthcare. While I attempt to acknowledge this in this short presentation, the audience will understand my expertise is with UK guidance and jurisdiction. The World Health Authority provides perhaps the best global standard that I can refer to and reminds us that excellence in end-of-life care is more than simply good and compassionate medicine. It has an equal foundation in international human rights law. And so we have an array of international committees from all continents which have published their own statements regarding palliative care, some of which you may recognise. And there are variations within local regulation, but it's possible to see how all are underpinned by Article 2 of the Human Rights Act concerning a universal right to life, balanced against Article 3, which prohibits torture or degrading treatment. So to return to the proposition, I confess I struggle with the double negative of arguing against and never. If I reframe the statement, am I being asked to argue for the fact that care should always be withdrawn? Clearly, I'm not trying to argue for such a proposition, but this throws light on the effect of our words. Such an important theme when we're handling ethically and emotionally complex situations. The words that we use, the talk we employ, is as powerful and potentially dangerous as any drug or scalpel, and our communicative interventions, be they written or spoken, demand as much respect as any other therapeutic measure. Let us quickly agree that to argue that care should always be withdrawn is a nonsensical proposition. Because I don't think the intention is that we're debating a withdrawal of care, but rather about a consideration of appropriate care. How easy it is to misspeak, how difficult to choose clear and delicate phrasing. It won't surprise you that I take this opportunity to remind you that palliative care is a highly skilled intervention. I argue heartily that what you might call generalist rather than specialist palliative care requires as much skill in the same way that a midwife assisting the birth of a baby in an uncomplicated vaginal delivery is no less skilled than a consultant obstetrician called to perform an emergency caesarean. When death is believed to be approaching, we do not withdraw all care. Rather, we prioritise the relief of distress over survival. Around the world and over time, how and when we do this has been contentious. In the UK, a well-intended tool designed to support professionals caring for dying patients, known as the Liverpool Care Pathway, met an ignominious end a decade or so ago, following outrage that patients believed to be dying were sometimes abandoned. A review chaired by the Baroness Julia Neuberger demanded a new system-wide approach to improving quality of care for the dying. Notable within this report is the expectation that any decision to withdraw or not start life-prolonging treatment should not be taken in any out-of-hours period. Moreover, patients should only be recognised to be dying by a senior responsible clinician, ideally in consultation with a wider healthcare team. These facts have significant practical implications for a 24-hour health service dealing with acute, unexpected neurological catastrophe. Evidence specifically for palliative care after stroke is scant. The situation is improving over time, and I have to thank Professor Mead for her work in this area. Surveys assessing public awareness of stroke in the UK following a large public health campaign, which encouraged early presentation after symptom onset, show stroke is recognised to be critical. But mainstream media and medical press give focus rightly to advances in stroke treatment, which perhaps raises the expectations of those acutely unwell in the ambulance on their way to hospital, and possibly also of the receiving healthcare professionals. While death is associated with stroke in the public mind, to now it is not something that is commonly mentioned, in contrast perhaps with contemporary discourse about COVID, dementia or cancer diagnoses. So there is no question that supportive care is important after stroke. May I suggest, therefore, that rather I am arguing that inappropriate treatment should never be performed. And may I beg a further rephrasing that for the purposes of this debate, we consider acute severe rather than merely acute stroke, a point I'll come back to shortly. We should also bear in mind that as well as ceasing treatment, we can elect not to commence at all. I'm pleased to adopt Professor Mead's definitions of stroke, but I must elaborate further. Let us consider what a severe stroke is. It won't surprise you, although it may disappoint you, to hear that I can't give a simple answer here. It's already been elegantly demonstrated that prognostic scores can be unreliable. Late presentation may render potentially restorative treatments less useful, thus established pathology might be considered more severe. Perhaps we might also wonder whether a late presentation hints at some reluctance to engage with healthcare. Comorbidity and indeed age are important to consider, but not reliable. What I seek to describe is that clinical judgment that balances the perceived degree of acute insult posed by a stroke against the physiological reserve of the affected body to cope with it. To that end, perhaps severity here reflects a high risk of imminent death. Recognising dying is exquisitely difficult, especially in acute situations. This fact was explored in some detail in the Liverpool Care Pathway report I mentioned previously. We know something about the trajectories of dying in certain diseases. Cancer and chronic disease have been relatively well explored, while dying from acute brain injury is less well studied. We know that we have a sudden trauma with an immediate risk to life, and where recovery is possible, life is likely to be shortened. If we don't doubt our ability to cure stroke, why would it occur to us to broach the possibility of death? It's so important that we recognise uncertainty. Of course, biases in our thinking do exist, and we should be aware of them as far as possible. A multidisciplinary team decision about possible prognosis may mitigate these biases and is standard practice in specialist palliative care. Again, we return to my favourite theme of communication. Communication is hard, especially with people who are not like us, those who don't speak the same first language, those who have a different life experience or different expectations of healthcare, or those who do not share our culture. But we should not shy away from it any more than we might shy away from a more technically complex intervention like surgery. But appropriate communication skills training is vital. Let us now turn to the definition of treatment. What is it that we are potentially stopping, or what indeed might not be given? Are we talking about not treating acute stroke, for example, with a thrombolysis? Or are we talking about removing more supportive care, such as hydration or symptom management? I put it to the audience that when the risk of death is high, we should not conflate not treating with causing death. Palliative care is not euthanasia or assisted dying. There is plenty of evidence, both historical and contemporary, that where modern high-tech stroke treatment is unavailable, untreated stroke is survivable. Treatment may on occasion have remarkable impact, but in severe stroke is unlikely to allow a complete recovery or cure. We must be careful not to offer a futile intervention that could be construed as an assault. As has already been indicated, stopping active treatment does not mean the patient will die immediately. In fact, I'm very aware of very few interventions which, if ceased, would cause the patient to die immediately. I don't have the luxury of being able to cite the opinions of the dead as evidence that death is a good or poor outcome, though doubtless if a survey were possible, we would find a range of views. A proxy measure in England is the Voices survey, a regular questionnaire offered to bereaved relatives. Importantly, when those who were bereaved by stroke were questioned, they explained what made care excellent was the perception that individual needs were met at the end of their loved one's life, including again that communication was exemplary. Importantly, we should also note that having enough nursing help is crucial to this group. My experience is that few patients are able to return home to die after severe stroke, often because of the high level of nursing care required. We must think honestly about iatrogenic harm. Bleeding risks with antithrombotics or perioperative hazards of thrombectomy will be well understood by my audience, but let us think in more mundane terms. What we might call simple hospital admission is not without threat. Those who suffer acute stroke are set apart from others with non-neurological disease in that they are likely to be obtunded, unable to explain their wishes, dysarthric, confused or unconscious. We presume to bring them to hospital, but we do not know if this is what they would have wanted. They are less likely to be in a position to consent to be transported away from home or to be able to resist assessment and treatment by acute services. Mention has been given to the low rates of advanced decision-making in the UK population. My experience is that even where an advanced decision exists, it is rare for it to be sufficiently specific that foregoing emergency care would seem right. In our time of COVID, visiting restrictions have had a profound impact on patients and their loved ones. We are painfully aware that patients have chosen to stay away from hospital, sometimes at great cost to their physical health, but perhaps not at the price of the comfort of their home. UK courts and the GMC have made plain that health professionals are not required to offer treatments they consider to be clinically inappropriate. This may be because it is not possible to provide the treatment, or the associated risks are too great, or where it would provide no clinical benefit. Turning to the thorny issue of feeding and hydrating patients after severe stroke, we must be clear what it is that we intend to treat. What is our clinical aim if we prescribe such therapy? Good palliation will certainly include mouth care. A patient may be able to manage sips of water or small amounts of ice cream, and this might be sufficient. Eating is a pleasure to enjoy. Not eating or drinking is part of the natural process of dying. If our intervention is in good conscience intended to relieve distress, it may be justifiable, but we must be careful not to prolong dying. I don't disagree with Professor Mead that in a crisis situation, capacity to take in new information and make decisions is compromised. I strongly contend that decision-making in any medical emergency rests on professional expertise. Patients and their loved ones have no right to demand treatment that is clinically inappropriate. We should not burden patients or families with the illusion that grim choices are theirs to make. Again, we return to the importance of communication. Supporting a patient's sense of autonomy often depends on how options are presented. At times, though, we must consider who we are treating. Is our patient the one in the bed or the one sitting alongside? Bereavement care is an important, often overlooked element of palliative care. While we do not wish to prolong suffering, it is true, as Dame Cecily Saunders said, that how people die remains in the memory of those who live on, and that for some families, certain supported treatments such as intravenous hydration are especially important. But this must be delivered judiciously to avoid complications like edema or worsened respiratory tract secretions, and reviewed regularly to ensure it is not causing harm. You may be aware that The Lancet recently published a document, the Commission on the Value of Death. It has a number of key messages, reflecting that dying in the 21st century is a story of paradox. Although many people are overtreated in hospitals, still more remain undertreated, dying of preventable conditions and without access to basic pain relief. Death, dying and grieving today have become unbalanced. Healthcare is now the context in which many encounter death, and as families and communities have been pushed to the margins, their familiarity and confidence in supporting death, dying and grieving has diminished. Relationships and networks are being replaced by professionals and protocols. Climate change, the COVID-19 pandemic, and our wish to defeat death all have their origins in the delusion that we control and are not part of nature. Rebalancing death and dying will depend on changes across death systems, the many interrelated social, cultural, economic, religious and political factors that determine how death and dying and bereavement are understood, experienced and managed. To conclude then, I put it to you that care should never be withdrawn after acute stroke, but we must be careful not to offer or begin inappropriate medical treatment. First, do no harm. Prognostic uncertainty is surely difficult. Communication is vital. We might reflect that death is systematically undervalued in modern high-tech medicine.
Unfortunately, we don't have Dr. England with us, but I'm very pleased to see that Professor Mead's here with us. So I will act as if I'm speaking on behalf of Dr. England. So let's first start off with Dr. Mead. Any comments you want to make in light of this very nice, elegant presentation by Dr. England?
Yeah, thank you. I enjoyed that very much indeed. Obviously, my argument is not something that I believe in. I have a much more balanced view than that, but for the purposes of this debate, I presented those views. I think one of the things that stood out for me from Dr. England's talk was the comment about the need for bereavement care and actually ensuring that dying after stroke is as positive an experience as it can be. And I've met many families who've had traumatic experiences, and it's made it very difficult for them to grieve. And I think we need a lot more research about how to provide support to families and subsequent bereavement care. There's very little in the literature. So that's all I'd like to say just now.
No, I do agree with you. I mean, I also have run a very busy stroke service over the years, and I think the points you make about how things can change, even though the trajectories can change, or complications that can arise, for example, and it's very difficult in the first day or two to make some decisions that could impact outcome. I also, as I listen to both of you, clearly agree with you that there's so much more work needs to be done. I can certainly appreciate very much the organizers here who thought of bringing the subject. I mean, I've been part of Connie for many years, and we focus on, subjects that are should be give statins or not. They should be treated with TPA versus TNK, all important subjects, but somehow this issue has been under the radar and we haven't discussed it as much, but truly a very important subject that impacts all our patients. So thank you again. Very, very nice presentations. We have to take the vote. And if you recall, Professor Meads, just to let you know, you were losing. It was 35% versus 65%. And if there's any consolation, I was in a debate just before you, and I moved from 65% against me to 54% against me. I still lost the debate. So I'm going to ask if the organizers can open up the question and see if we can have a vote again. And hopefully after that, we will let you go, Dr. Mead. Thank you again. It was nice meeting you. So let's have the vote.
Number that I used for the purpose of the debate. I suppose from a clinical perspective, the prognosis becomes a little bit clearer as time goes on, and at 5 days, you've got a sense, I think, of whether somebody's deteriorating or improving, but I think it's an arbitrary number, and as I'm sure the person who's asked the question is aware, that everybody's very, very different, and it's very hard to generalise in this area. So I hope that's of some help.
Excellent. Oh, look how well you did. Did you see the results? Can you see the results? Oh, wow. I wish I could have such results. So it's moved from, you moved from 35% to 83%. You just nailed this debate. We should have you officially as our debater every year.
Well, thank you. But I'd just like to say that those are genuinely not my views. They were purely for the purposes of the debate. So I'd just like to emphasise that. But thank you.
No, those are excellent. We all have to take a position as has been asked us to take. But I think I certainly learned a lot from the two excellent presentations. Thank you again. Appreciate